Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm continuing to talk about thrombophilia, DVT, and pulmonary embolism. When I left off last week, I did 3 half-hour shows explaining what thrombophilias are, how they can go about causing somebody to have a clot, the different types of clot, etc. In this segment, I'm going to begin to talk about deep vein thrombophlebitis itself, DVT. DVT occurs in the low flow system, that is the venous system. Okay. When someone presents with a DVT, almost always they complain of the leg that is swollen. Very rarely a DVT can occur in the arm as well. It will be swollen. Sometimes there's pain, sometimes there's no pain. It's usually unilateral in one leg or the other. Then, of course, you take a history from the patient. Very important. Have you traveled? How far did you travel? By car, by plane, and so on. That's very important. Were you sick in bed for lying in bed for several days, etc.? Did you have a trauma, one type or another? Then you take a history. Do you have any people in your family that have had history of DVT? Have you had DVT in the past yourself, and so on? Then you go and ask them, are you taking any hormonal substance, be it over the counter or be it prescribed? That's very important, because if you take in hormonal substances that are over the counter, that can cause you to clot, even though you didn't realize that you had an underlying thrombophilia, and so on. When you finish taking the history, of course, then you examine the patient. You do a thorough examination, the vital sign, examine the lungs, examine the heart, the abdomen, etc. You do a neurological examination, so on and so forth. Then you evaluate the leg itself, measure it, touch it if it's tender, and so on and so forth. Is it discolored, and so on and so forth, because it could very well be a cellulitis. It may not necessarily be a clot, so looking at the skin is very important. Then, of course, you're going to start quickly. You will send the patient to have an ultrasound of the lower leg. Ultrasound of the lower leg will pick up a DVT 99.9% of the time. And then once you do that, while the patient is going for the ultrasound, you also want to send the patient to have a complete blood count, a urine analysis, complete metabolic chemistry profile. You want to do a PTT, INR, to make sure that there is no underlying abnormality involving those that can prohibit you from being to anticoagulate the patient, and so on and so forth. And then patient comes back, got all your results, there is a DVT. Fine. Then, before you do anything, you're going to get yourself a hematologist to do what's called a hypercoagulable evaluation. What do I mean by that? Well, you're going to do several of these things that are listed there. You're going to do an antithrombin 3. You're going to do a homocysteine. You're going to do a protein C level, protein S level. You're going to do a lipoprotein level. You're going to check for that. You're going to check for the prothrombin mutation level. You're going to check a factor V Leiden, which is seen mostly in European folks. You do a lupus anticoagulant, and then you do all these different things depending on what you think may be going on. That's very important, because if you start heparinize the patient before you do this, some of them will not be affected by it, some of them will. So therefore, it's best you send all this thing off, and then once you send them off, then you could begin treatment right away. You cannot wait. You have to begin treatment immediately. Once you begin the treatment immediately, then you wait for all these results to come back to see which one is responsible for the DVT. There's sometimes, very rarely, that someone may have a DVT, for that matter, a pulmonary embolism, and we never found the cause. That is very rare, but it can happen. Now, then comes the decision, what is it you are preventing. You're not only treating the DVT to try to dissolve the clot, you're trying to find the reason for the clot, and then you also want to particularly prevent two things. You want to prevent a pulmonary embolism because the clot can dislodge and get shoot into the lung to cause a pulmonary embolism. And it can also dislodge and get shoot to the lung to cause sudden death, something called a saddle embolism. Saddle embolism is when the clot occurs in the area where the left lung meets the right lung, and that intersection right there. If a clot finds its way there, it's immediate sudden death. No if or but. Within seconds, the patient is going to collapse and die unless there's somebody there to quickly do assist the patient until help arrives. Now, if you know that the patient has any one of these thrombophilias and you're going to, let's say, do surgery on this patient, in addition to treating the patient, which I'll show you what medication to use, you must also do what's called an you must place an inferior vena cava filter. The inferior vena cava filter will grab the clot, preventing it from being dislodged to the lung. The filter will grab it. That's very important. Nowadays, I've seen surgeons who are preparing people for major surgery, in particular prostate surgery. Now they're doing it not routinely, because I can't say that, but I've seen several of my colleagues in the hospital where I'm associated with that are in fact putting the filter, because they had to put this, because as I said last week, one of the unfortunate common things that happen is sudden death after prostate surgery. And almost always, 100% of the time, is because the patient had one of these things and they did not know that the patient has this abnormality in his blood, and then now that he just had surgery, he's laying in the bed a day or so later, and suddenly they found the patient dead in the bed from a clot. Okay, this is so common. Now I've seen some of my colleagues are automatically putting the filter as part of the surgical procedure that they're doing to prevent that. They put the IVF filter. Okay. Okay. Now, one other thing: once you have the clot in the leg, you must also do what's called a D-dimer. The D-dimer is crucial because you're going to follow the level of the D-dimer that tells you how quickly you're dissolving the clot. So long as the patient is clotting or the clot is still active, the D-dimer level is going to be high. So you do your baseline D-dimer, and then gradually, every other week or so, you repeat it to see how much progress you are making. As long as clotting is occurring, or the clot is still fresh sitting there, the D-dimer is going to be very high. So now you know, use the D-dimer to monitor, because you can't send the patient for a ultrasound every week, every 2 weeks. It doesn't make any clinical sense. But since you're going to keep watching the patient anyway, you want to make sure the patient is well anticoagulated. And the way you figure that out, you do a PT-PTT-RNR. If the PT-PTT-RNR are elevated, then you know the patient is well anticoagulated. In addition to that, the D-dimer is coming down. Almost remember this. Again, you need to put this in your pocket. Never fail to do a D-dimer in a patient who presents in the emergency room with chest pain. Don't always think that it's cardiac. Everybody who presents in the emergency room, shortness of breath, chest pain, you make it your practice to always do a D-dimer. You will be shocked and amazed how many times you're going to diagnose something that is not the heart, but it turns out to be the lung. Remember, thousands and thousands of people died every year in this country, and for that matter across the world, with pulmonary emboli. Nobody knew anything about it. It's only an autopsy. If an autopsy is done, you find, oh my God, patient had pulmonary emboli. This past year, 2018, 2 patients of mine showed up at the hospital up the street here on Post Road on Davis Avenue. Absolutely zero cardiopulmonary symptom, no shortness of breath, no chest pain, no tachycardia, no fever, no sweating, none of those things. But this patient had clot in the leg. And I have decided to admit the patient in the hospital so I can do a proper workup and treat the patient properly. But something tells me based on experience, Val, I tell you what, why don't you also do a CT angio? The CT angio is a CAT scan. Do a CT angio to see if there's a clot in the lung. These people have zero symptom of any type of evidence clinically that they have clots in their lung. Both patients in 2018, both times, had pulmonary emboli in both lungs, left and right, both of them. You can't make this up. Both of them had clots in the lung with zero, completely total cardiopulmonary symptom that would have made me suspect that they may have clots in the lung. How about that? Suppose I didn't do it. This is what I kept saying. I say it all the time. In order to practice quality clinical medicine, number one, you have to have knowledge. Number two, you have to have experience. And number three, you must have judgment. Those are the three things. Those are the three things that get you through the day, helping patients without getting yourself into trouble. You must have those things. That's it. And those don't come overnight. Just like it takes a long time for a bottle of wine to mature so it can taste properly. It's the same thing. It takes time. You can't rush it. You absolutely cannot. I've been at this for 47 years. 47 years. Just about 24/7. When I used to travel a lot in my earlier days, I used to carry a laptop. I used to go away just so that I can write. You can't make this up. To get a couple of weeks, just go away, take my laptop, and write books and stuff, write articles. I did that for years because that is all that I'm interested in besides just being a human being and do the usual stuff. My main interest, only interest, is general clinical medicine. I have completely devoted myself to that. And I'm not unique. A lot of my colleagues have done the same thing. This stuff is so difficult. It is so hard to practice bedside clinical medicine. You must have a total and complete devotion to it. It's an art. You must know all that about the science, but to be good at that art, you must really do it again and again to the point where it becomes just about second nature. Okay? So now that you've diagnosed this DVT, and you know it's in the venous system, how are you going to treat it? Well, it's a clot. It's in the low flow system. I told you the clot that is forming the low flow system has very little platelet. It's mostly red blood cell and debris. But even though it looks red, there's very little platelet in it. So anyone who tells you that they can really take the responsibility of treating a patient with aspirin or aspirin-like medication for clot in the lower leg or anywhere in the venous system, please get yourself a jet plane and run away from them. It's not going to happen because there isn't enough platelet for the aspirin to disaggregate, to dislodge, to prevent the clot or to dislodge it. There's not enough. This is a platelet-based mechanism. And aspirin works to prevent clot specifically or to treat clot where there are a lot of platelet. That's it. Simple as that. That's it. Okay? So therefore, now that you've done that, make sure you do your CT angio to make sure there's no clot. That's very crucial because clots in the lung are treated differently from clots in the leg. The time period is different. You treat a clot in the legs for 12 weeks. You treat a clot in the lung for 6 months. That's it. Big difference. Huge difference. Huge difference. So now that you've done that, you give the patient, you're going to treat the patient either with heparin. You could heparinize the patient very cumbersome these days because heparin, though it is a big important medication, but you have to be doing PTT every day, stick the patient every day, and then you run the risk of heparin-induced thrombocytopenia, which is a can be pretty deadly syndrome if you don't recognize it. Up to 2% of individuals in this country who are on heparin going to wind up developing heparin-induced thrombocytopenia, which is can be a very deadly situation. So you avoid that by giving the patient Lovenox. The chances of heparin-induced thrombocytopenia developing when the patient is on Lovenox is very minimal, much less than heparin itself. And by the way, once you develop heparin-induced thrombocytopenia, you are allergic to heparin for life. Even the tiniest little bit of heparin that is used to keep a vein open will get you into trouble. How about that? So it is and then it's very cumbersome. That's what we had to do because that's all we had. It's very cumbersome. You have to be drawing blood from the patient every day, measuring the level of the PTT, and so on and so forth. But let me make a point here. Again, I'm making a very important point because people are using heparin all the time, which is a good medication. There's a reason for them not to use it, but it's cumbersome. You have to understand something. The normal partial thromboplastin time is somewhere around 32, 33, 34. Okay? There you go. Now, when you put somebody on heparin, this is the key thing to understand because people go crazy raising the dose of the heparin, doing this, doing that. They don't understand. You have three coagulation systems: the intrinsic pathway, the extrinsic pathway, and the common pathway. Okay? The common pathway has nothing to do with heparin. That's a different story. Excuse me. However, the extrinsic and the intrinsic pathway, heparin will affect them. Here's the point I'm trying to make. This is a very crucial point to understand so that people don't keep raising the heparin to raise the PTT, blah, 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 blah. Here's the deal. You don't have to be doing PTT. First of all, you don't do PT at all because PT basically in this setting is handled a different part of the pathway. What you do is basically PTT. You do a baseline PTT to make sure that the patient doesn't have a bleeding problem, or for that matter, the patient doesn't have a situation whereby no matter what you do, you cannot raise the PTT. The platelet factor 2 abnormality can cause that to occur. Once you got your baseline PTT, you know the patient is okay to go. Only thing you need to do is to put the patient on heparin, give them the bolus, and repeat the first PTT subsequent to that to make sure they are well anticoagulated. If, no matter how much heparin you're given, you still cannot raise the PTT, then you got a platelet factor 2 abnormality that's blocking the ability of there are many, I'm just giving you one example. Or the patient had some other issues, maybe had, heparin-induced thrombocytopenia that wasn't picked up, which is quite common, and now he or she is resistant to heparin. The minute that you raise that, the point I'm making is that in order for you, listen to this carefully, in order for you to raise the PTT from 32 to 34, 35, 36 to 45, listen to this, to raise it to 45, you have had to have wiped out the entire intrinsic factors. You had to have wiped out the entire extrinsic thing. So therefore, what is the point of raising the heparin to 80, to 60? What are you doing? You just don't understand the process. You can't thin the blood any more than that because in order for you to raise it to 45, you already wiped out your entire insurance. You have to. Otherwise, it would not have come up to 45. So what is the point of trying to raise it? And what it is you want, you just don't understand what you're doing. You're wasting and endangering the patient. You do not understand the process. If you don't understand the process, then you ought to get yourself a hematologist who understand coagulation. Not all hematologists, believe it or not, understand coagulation itself. I was very fortunate. Very fortunate. Not only that I was a medical technologist, but I was fortunate that I was trained by Dr. Ted Spade at Montefiore, who was, when he was alive, the leading coagulation expert in the world. You have to understand there were 7 of us that were taken, several thousand applied for the 7th spot, because most of the major hematologists and the major medical centers in the New York tri-state area, they were all trained by Dr. Spade. How about that? And one of the things that he made us do, believe it or not, we had to do our own tests so that we can not only understand the theory, he forced us to go into the laboratory to do our own. We don't just let the technique, no, we had to go in the lab and do it ourselves so that we really have a complete appreciation of what we were doing. Another thing that Dr. Spade did for me and all of us that he trained, I will never forget. You dare not, let me repeat this, you dare not be given a conference in the presence of Dr. Spade as his fellow and have a piece of paper in your hand. You couldn't, he will stop you. In the middle of the conference, he will put you through shame by say, Val, put it down. Put the paper down. Okay? So it doesn't matter whether you're going to really talk for an hour or two. Dr. Spade did not expect you. You have to know the stuff so well that you have to speak extemporaneously like I'm doing right now. That's exactly correct. All of us had to give a seminar as part of our training. All of us had, doesn't matter how complicated the seminar was, the whole audience were there, you had to stand there and do it. If you couldn't do it, then you were not ready. Okay, you had to come back and present it again. You can't make this up. So consequently, all of us that were trained by Dr. Ted Spade, God bless his soul, rest in peace, had to stand there, and every other week, it was one of us had to present in a round. Can't have a piece of paper in your hand. You might have a couple of things, that numbers you put on the black, but that's it. Otherwise, he will stop you. Yeah, Val, put the paper down. And you got dozens of people sitting there. What you going to do? Put yourself to shame? You got to continue. So as a result of that, all of us can stand there extemporaneously, talk about anything having to do with medicine or hematology, because that's the way we were trained. So therefore then, now you understand the process of anticoagulating somebody can be very dangerous. You have to know what you're doing. You could hurt somebody. You could cause bleeding. Listen to this. Heparin can cause bleeding, and heparin can cause clotting. How about that? So you have to know what you're doing or else get help, because you're dealing with a patient whose life you have promised, you've sworn to save, whose pain you've sworn to relieve. Okay? Therefore, then, you could use Levinox. When you're using Levinox, then you don't have to worry about all this doing PT, PTT, whatever. You just do the baseline, you put the patient on Levinox. Now, if you're going to have to put the patient on Coumadin, which most of the time that's what we had to do, which is being done all over the world, that another complicated things. Another totally complicated thing, because once you start patient on heparin, all here in this book is a step-by-step thing. All the factors goes down by them, not the same day. They just go down 24 hours, 48 hours. It took you up to 4 or 5 days to wipe out the whole thing in order for the patient to be truly, completely anticoagulated. So you can't just jump, put somebody on heparin and switch them over right away to Coumadin. It doesn't work like that. This is complicated stuff. If you don't know it, well, ask for help. Now you understand, just because somebody is on heparin Doesn't mean just put the heparin and go walk away. It doesn't work like that. So Coumadin, then you don't have, Levanox, you don't have to worry about repeat PTT. You just put the patient, calculated the dose based on the creatinine clearance, blah, blah, blah. Give him 60 milligrams twice a day, 80, depending on the patient's size and creatinine clearance, etc. Okay. So you anticoagulate your patient. Then if you have to recombinant, you can't just because you start the patient on Coumadin, you're going to stop the heparin. It doesn't work like that. It takes up to 5 days for the full effect of the Coumadin to knock out all these factors. Let me repeat that. It up to 5 days. Just because the patient is on Coumadin today doesn't mean you could walk away and stop. It doesn't work like that. You have to keep the patient on the heparin while you gradually increase the dose of your Coumadin until up to 5 days later. Then all the different factors now have been affected by the Coumadin, because the Coumadin works differently than the heparin to affect the factors. It takes up to 5 days for the Coumadin to kick in. Remember that, please. Up to 4 to 5 days for the Coumadin to fully kick in once the patient is on heparin. Don't just switch one day to the next, then you just wasted the whole thing, because the patient is going right back to where she was, because the heparin only lasts for 24 hours. And after that, your patient basically is not anticoagulated. Just because you just put them on, doesn't mean they're anticoagulated. It takes up to 5 to knock out the different factors, factor 2, factor 7. It takes time for them to go down. So now you understand that. It's a very complicated process. And then, of course, you have to watch the patient, to watch the red blood cell count, to make sure the patient is not bleeding. That's another thing you have to watch for. Watch for bleeding. But don't be watching for bleeding just because the patient PTT is 80. Why is it 80? If you had to go to 80, something is wrong. Then go back, reevaluate. It doesn't work like that. There is no need to raise a patient PTT to 70 or 80. What are you trying to do? Cause the patient to bleed? Which is what's going to happen. Okay. So this stuff is complicated. It's coagulation in general. It's of all the incredible intellectual stimuli one get in the field of hematology. I'm here to tell you the coagulation has got to be one of the fascinating ones. Hemoglobin issues and coagulation, those are the most intellectual aspects. First of all, hematology in general is extremely intellectual. It's extremely intellectual, fascinating stuff. Okay, so therefore then when you start the patient on treatment, I will tell you next week how much and how long you keep the patient on treatment and for what reason, etc., etc. So next week I'm going to continue to talk about the treatment of DVT. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.